Good evening, everyone. My name is Rona Wilk, and I'm the president of the class of 1991 and a member of the Project Continuum Committee of the Alumni Association of Barnard College. And it is my enormous pleasure to welcome you to Let's Talk About Menopause, Part 2. What's new? What's next? After our first menopause event in 2023, What to Expect When You're Expecting Menopause, many of you asked for a part 2, and we are delighted to present this dialogue and hope that it will prove just as helpful and informative as the first session. And actually, we're going to put a link to part 1 in the chat, so in case you missed it, you can check it out. This event is sponsored by the Project Continuum Committee, class of 1991, and the Francine A. LeFrak Center for Wellbeing. I'd also like to note that now menopause is in the zeitgeist, but we, Barnard, got there first, so as we should. A little housekeeping. As a reminder, this event will be recorded and the recording will be made available to registrants. Also, this online event enables an attendee. Actually, this does not enable an attendee to participate through a personal device, microphone, and/or camera. So this is a totally useless piece of housekeeping. But you will be able to submit questions using the Q&A feature throughout the program, and we really encourage you to do so. One of the main purposes of this event is to empower you so that you can make the most of the limited time that we all get with our physicians these days. So I'm delighted to introduce Dr. Marina Catalozzi, Barnard's Chief Health Officer, who will introduce our guest speaker, Dr. Anna Barbieri. Marina Catalozzi is a board-certified pediatrician and adolescent medicine specialist. She currently serves as the Chief Health Officer at Barnard College. In her former inaugural role as the Vice President for Health and Wellness, Dr. Catalozzi led the vision and construction of the Francine A. LeFrak Foundation Center for Wellbeing, as well as the Primary Care Health Service and the Rosemary Furman Counseling Center, the college's response to infectious disease threats, read COVID, and new medical and public health research opportunities for Barnard students. Dr. Catalozzi is the Executive Vice Chair for Pediatrics at the Columbia University Irving Medical Center, where she is an Associate Professor of Pediatrics at the Badgelas College of Physicians and Surgeons, and also Associate Professor of Population and Family Health at the Mailman School of Public Health. Her recent research has focused on adolescent and young adult access to confidential and preventative services, and she uses a strength-based approach to adolescent patient care, programming, and research. And I now turn it over to Dr. Catalozzi.
Rona, thank you so much. And I just want to warmly welcome everybody. I know that I do adolescent medicine, but this is a topic near and dear to me, as I'm sure to many of you who are on this webinar this evening. It's so wonderful to have so many Barnard alumni here for part 2 of our menopause series. If you joined us the last time, you'll remember, as Rona said, we really focused on what to expect. Tonight, we're going to get more practical. So what are the tools, the treatments? How do you take charge of your care? And I am just so absolutely delighted to be able to welcome Dr. Anna Barbieri, who's a board-certified gynecologist, a certified menopause practitioner with advanced training in integrative medicine. And Dr. Barbieri is really dedicated to delivering truly personalized, patient-centered care. She specializes in perimenopause and menopause management, tailoring nutrition, lifestyle strategies, and hormonal and non-hormonal treatments to each patient's unique needs. As the founder of an integrative women's health practice in New York City, Dr. Barbieri provides expert care in gynecology and women's hormonal health. Her practice also offers specialized support in the areas of sexual medicine, nutrition, cognitive behavioral therapy for insomnia, and integrative primary care. She's also dedicated her care to women at high risk for or recovering from cancer. Dr. Barbieri completed her residency in OB/GYN at Mount Sinai Medical Center in New York City, where she now serves as an assistant clinical professor and clinical strategy leader for the upcoming Rowan Center for Women's Health and Wellness. She's a certified menopause practitioner through the Menopause Society and a fellow of the University of Arizona's Integrative Medicine Fellowship. Additionally, she's the founding physician of Electra Health, a digital menopause healthcare company, and an extremely proud Barnard 26 mom. Dr. Barbieri, we are so fortunate to have you here today. There are so many people who don't have expertise in this area who are providing care. So to hear from you is really so important. And I think my first question to you really is, in 2025, what mindset really matters the most when we're thinking about menopause?
Thank you so much. And first of all, thank you so much for that lovely introduction. The most important part of that is that I am a super proud mom of a Barnard College student now. And I have to say, maybe I told this story on our last webinar, but when I went to all these different college visits with my daughter, she walked onto the Barnard campus and 10 minutes into it, she says, "This is where I belong. And these are my people." And I have to say, when I gave my last talk 2 years ago, I kind of felt the same. Like there is something very, very special about this group and about this atmosphere and, as the kids say, this vibe in general. So thank you so much. And I'm thrilled to be here and share some information with you. So I think, the way we're looking at menopause now, it's changing. This was a topic that was quite taboo, that was something to be embarrassed about, that tied into sometimes our feelings about what we mean by beauty and youth and what really mean by the value of being a woman. And that's actually being called into question now. And I really like that. Menopause is getting its time in the limelight, and it's the conversation around it is changing. And I think the mindset in 2025 is that menopause is a part of life for right now. It's an inevitable part of life. We're actually lucky to experience it if we live long enough. That wasn't always the case in history. And that it is a normal transition. It's like puberty or pregnancy. It carries a number of changes with it. And that rather than consider it a medical problem, we should actually treat it as an kind of a call towards our own shift of identity and our own evolution. That's kind of my view of menopause and perimenopause that leads to menopause later today. Although I have to say, I am a little bit worried about how menopause is becoming somewhat medicalized, and a lot of the approaches to it are becoming prescriptive. And I think that our transition into this next chapter is complex and multi-layered. It affects us in different ways. And rather than looking for just, a way to prevent it, erase it, treat it, cover it, like we really should look at all these different aspects of it and not suffer certainly in silence, because that does bring some negative symptoms with it for sure, and maybe even negative consequences to long-term health. But we really should look at it as a process of evolving into this next phase of life.
I really love this life course approach that you're taking, because I think that, again, when you're not speaking about a certain phase of life, it is not actually something that's happening. And I often think about that for adolescence, right? Like it was never discussed as an option as a phase. You just went from being a child to an adult. So in many ways, this is the evolution of our adulthood. I think one question I have, and I feel like so many people approach me with this feeling of being off, like I'm having trouble finding words. I'm not myself, but I don't understand what's happening. I've never felt this way before. What are some simple steps that women can take if they're really just starting to feel not themselves? Their body is not the same as it was, and they're having these very vague symptoms. What do you
Yeah. And it's so true. This is one of the most common reasons why new patients seek us out, or any sort of menopause practitioners. And I literally hear those words sometimes multiple times a day. I don't feel like myself. I want to go back to feeling like myself. And I think right there that illustrates both kind of the complex nature of this change, where the changes, we can notice them, but they can be really subtle and we have trouble naming them. And also our kind of sense of dis-ease with this change. I just want to go back to who I was 5 years ago because I felt pretty great there. Well, unfortunately, we can't go back there. So this is even with all the different tools we'll talk about today, we can't rewind. We can just feel better now, feel better in the future, and evolve into the people who you want to be. So I think my first sort of advice would be, when we think of like, oh, I just don't feel like myself, I can't put my finger on it. Let's think of what that means. Because for me as a practitioner, that's also going to help me figure out where someone is and how we can approach it. What does it mean that we don't feel like ourselves? Does it mean like that I can concentrate as much and it's taking me 3 times as long to go through my emails, and that now I forgot something and I'm worried about raising my hand or speaking up in a meeting? Does it mean that I'm constantly checking stuff in my house to make sure I unplugged the iron because I worry that I left it on? Does not feeling like myself mean that all of a sudden maybe the sexual expression of my health is not there and I've lost my enjoyment of that part of intimacy in my life? Is it because now I wake up at 3 a.m. every night and I can't get a good night's sleep and I don't know why that's happening? I used to be able to fall asleep on command, anywhere, anytime. Or is it that I am literally seeing my body change in front of my eyes when I look in the mirror and I have this, I am becoming my mother or I'm becoming my grandmother moment, and now my shape looks different and that makes me uncomfortable and I can't put on my pants? Or is it because all of a sudden I'm getting blood work done and my cholesterol is off? It's all, it's really brings about changes. And just like we can tell when a child goes from being a child to being 16 and they've crossed that phase, they've experienced the phase of puberty, that's very different and the change is obvious. When we're just starting to get into it, that change between 10 and 11 may not be that stark. That change from 43 to 46 may be much more subtle, but which is it? What part of it is really making me say that I don't feel like myself? And who am I really? who am I now? Who was I before when I felt well? And how do I really want to feel in 6 months, in 2 years, in 5 years? So my first call to action would be like, what is that definition of myself and where do I want to go?
I think thank you for having so many of us feel seen. A lot of the things that you mentioned, it's really distressing, and that idea of dis-ease, right? That it's not quite a disease state, but this idea of why can't I get through things quicker? Why do I need more sleep, but I can't get it? All of the things that you talked about. I mean, I have heard you say before, and this really changed something for me when I first heard you speak about this, that lifestyle is foundational, not optional. So I think it'd be helpful for the audience to really hear what you mean by that.
Sure. And I'll just say, I am 51. I have experienced every single one of the things that that we just spoke about. And lifestyle is foundational, right? Everything starts with it. It's not optional. It is something, and lifestyle is every day. It's not a crazy diet. It's not it's not turning off my phone for an hour a day. It's like, although that could be a good habit too. I should do that. But it's really something that we have to start with. There are different components to our kind of foundational lifestyle health. These days, there's even a branch of medicine called lifestyle medicine that focuses on that. Finally, that's getting recognized also. But it's really having to deal with things like nutrition. We all have to eat, sleep. We all have to sleep. Movement rather than exercise. It's really how we use our physical bodies, these vessels we live in. It's really about our mental health and relationships, relationship to ourselves, relationships to those around us, relationships to the broader community. And it's really about the kind of defining what life means to us at any given moment. What is that larger meaning? So I don't think we can overlook those because those are really essential components of health. I think we can broadly define them. None of these items has a single perfect prescription that exists. There is no single perfect diet that applies to everyone. I think we can on a very wide sort of from a wide lens perspective, say that yes, reducing or eliminating sugar, reducing or eliminating alcohol, reducing or eliminating processed foods are all great bets. Beyond that, people have constant arguments about going vegan, plant forward, vegetarian, keto. These are all different iterations of different diets that currently there is probably a certain diet that's optimal for an individual, but that's very different on a population basis. Movement, as much as we can, of movement that we enjoy is great. I would say there is definitely research that shows that for women in this age group, so certainly midlife, so let's say 40 to 60, but this would apply much broader also, a combination of high intensity cardio with strength training, and strength training is essential, it's very important. But more important than that is being consistent with something, not getting bored of it, and doing something that we enjoy and really moving. I think the saying is that it takes sort of 3 days of no exercise to really feel the effects of that, but it takes 3 months to get that back. And I certainly feel that, at my age. I think it's also important to recognize that this is a time of life that's where we have a lot of stresses. We have a lot of professional stresses, we have financial stressors, we have caregiving stressors. I just gave a talk on women in midlife and their professional obligations, and we can't talk about those without talking about our personal obligations. Over 70% of unpaid caregiving labor in the world is done by women. This is a time in life when we're often taking care of our children. They depend on us for longer these days. We're often caring for elderly parents and relatives at a time where our own health may be suffering. So it's really stress management, making room in our life for all the different needs that are present there for us, setting aside time to truly, truly take care of ourselves. These are all very important things. So we can't, I know this is not what we're focusing on in this webinar, but I can't discount those items. Everything starts there. The other side of that coin is, unfortunately, for some of the menopause symptoms, we cannot diet ourselves out of them or yoga ourselves out of them. Like we have other tools at our disposal for that.
Yeah, and it's so helpful to hear you say, there's no one size fits all, there's no specific diet. It's really, sometimes trial and error, understanding, how you respond to things. But I think you are right. I mean, it's time to talk hormones. That is the question on everyone's mind. And hearing a little from your perspective, really, what is it, and really who's it for? Because I think there's a lot of misunderstandings out there.
Yes. So let's talk hormone therapy. So this is probably the biggest bucket of tools that we have to deal with menopause symptoms and perhaps even consequences of menopause. There's some other buckets out there, but let's focus on this one. So hormone therapy for menopause symptoms has been around for quite a while. So I'm also kind of like a medical history buff, so I have to spend 30 seconds on this. When you first start really seeing sort of recorded history on women and menopause symptoms, we're going back to maybe mid 19th century. And some of the, reported sort of home cures, this is before hormones, were not dissimilar to what a lot of women use now to feel better. And those two items were alcohol and cannabis. So things have not changed so much there. There's a lot of, a lot of people kind of self-treat with those. Hormone therapy comes into use very early on, first as literally ground up ovaries from cows. It was noted that when those were administered, people would feel better. Estrogen, as the sort of the main sex hormone in women, was isolated in the 1920s, and it became commercially available as Premarin. And some of you may have heard this word because this product is still on the market in 1942. And it wasn't until about the 1960s, with a publication of a certain book, it was called Feminine Forever, that hormone therapy came into very sort of a much wider use. And that book was written by a man and basically advertised estrogen as the way for women to stay young and sexy forever. So hormone therapy takes off. At first, people did not realize that you needed to administer estrogen with its kind of sister sex hormone, progesterone, to prevent uterine cancer. So in the early 1980s, it was realized that that needed to be added. And then we were kind of off to the races. By the year 2000, many women, over 30% of women transitioning into menopause in the United States, were using some sort of hormone therapy. That came to a screeching halt with a publication of Women's Health Initiative, which was a big study published in 2002 that tried to look at the effects of hormone therapy, particularly on cardiovascular health. And there were many studies before that showed a correlation between hormone therapy and improved heart health. And lo and behold, the study did not show that. And one of its conclusions, and we can argue whether that was right or not, it showed an increase in the risk of being diagnosed with breast cancer. So that study was halted. The headlines were out there: hormones cause cancer. And basically, literally overnight, hormone therapy prescriptions fell by 80%. That study alone, and again, the results were recalled by its authors several years later. There were issues with statistical analysis of the results in the study. There were also differences in patient selection for it. Hormones in that study were given on average to women in their 60s, and they were not the regimens that are being used today. So there's a lot of issues with it. Was it the wrong population? Was it the wrong regimen that was administered? Were the results, analyzed incorrectly? But nevertheless, I mean, this is like Monday morning quarterback. What that resulted in is an absolute decrease in hormone therapy utilization. Not only that, fear, and really a decrease even in provider education on the topic of menopause and hormone use. Like, I graduated medical school in 99. I don't know, Marina, when you did.
I graduated in 96. Yeah.
I cannot recall a single lecture on menopause in medical school. I did an OBGYN residency. And menopause was this black box that was super complicated. And then the study came out, and oh, good, we don't need to address it now because there's nothing to do anyway. So,
Right.
and that really, I mean, that impacted everyone to this day. And it's just really in the last 2-3 years that we're seeing an uptick in the interest in menopause on the part of the healthcare profession. So, which is, I mean, that was, the study did a terrible disservice to, I think, women's health in terms of attention to this topic. It was sort of just dismissed. So where are we today? So we're in a very different place. Hormone therapy, and even all the major societies agree, is really the most effective way to treat symptoms of the menopausal transition and classic symptoms of menopause. That's going to include things like hot flashes, night sweats, sleep disruption, often mood instability, emotional dysregulation, vaginal dryness. Often libido will improve, although we also have testosterone for that. It's proven that hormone therapy results in a decreased risk for osteoporosis. That's also one of these kind of quote unquote boring topics, but yet we have a 30% chance of dying if we break our hip in the subsequent few months. Like, it's not, it really should be mentioned. There is a lot of data showing the promise of HRT on cardiovascular outcomes. It's a little bit harder to tease out. That's why it's not in the major society recommendations. But certainly when we start hormone therapy, especially around the time of entry into menopause, we do see beneficial effects on our cardiovascular systems. Lots of women women report improvement in skin, hair. There is also a link between hormone therapy use and decreased risk for diabetes. Although not a weight loss therapy, HRT has also been shown to perhaps limit our weight gain, especially in the middle. So, right, we're all familiar with that menopause belly weight gain. Hormone therapy can limit that. Again, it won't make us lose it. And there's a lot of promise in the studies on hormones and cognitive health. It's not part of the guidelines yet, but there is a definite association between the sort of the hormonal cliff we go through in menopause and changes in cognitive health. So if you don't make me talking for 2 more minutes, I'm just going to say what I say to all my patients who are considering starting hormone therapy. So this is my 2-minute HRT explainer. Sounds good?
Perfect. That could not be more perfect.
All right. All right. So here we go. So this is how we can think of hormone therapy for menopause. Number one, what do we call it? It used to be called HRT, and we often talk about it in those terms. Currently, the more appropriate term is MHT, and that stands for menopause hormone therapy, to differentiate it from HRT, which is full hormone replacement, which is something, for example, that we would do for someone with premature menopause. They need full hormone replacement. Someone that we would do for somebody going through a surgical menopause when they are way off from menopause yet. And that is also the type of therapy that is used for transgender protocols, because it's really hormonal replacement with a certain regimen. Most of us really looking at using hormone therapy in menopause are really talking about MHT. But for this webinar, I think whether we say HRT or MHT, what we really mean is like hormones we use in menopause. So here's how we think about it. It's important to know the terminology. So when I talk about starting hormone therapy with one of my patients, we're all on the same page. So number one, hormone therapy can be systemic. So systemic hormones affect all the different parts of the body. We have receptors for hormones all over. Systemic hormone therapy is the type of hormone therapy that can affect your sleep, your mood, brain fog, hot flashes, night sweats, and so on. As opposed to local or vaginal hormone therapy, that's important, but that's really used for things like vaginal dryness, painful sex, prevention of urinary tract infections. Most of the controversy surrounds systemic hormone therapy. Vaginal hormone therapy is quite safe. It really, I mean, there's even talking about not making it a requirement to write prescriptions for it, and it's extremely useful, but it does not carry either the benefits nor the potential risks of systemic hormone therapy. The second thing is this issue of, okay, what's bioidentical or body identical or not bioidentical or synthetic? And that's sort of, it's confusing because I do think that people, and even including certain social media accounts, are not using these terms correctly. So all bioidentical means is that the hormone is in the same chemical shape or the same molecular form as what the human body makes. That's it. So when we're talking about estrogen can be bioidentical or not. If you think of that, my story, how Premarin came out in 1942. So Premarin is a natural product. It comes from the urine of pregnant horses. That's where its name comes from, pregnant mares. Premarin is not bioidentical, right? A birth control pill does not have bioidentical estrogen in it. It's a purely synthetic estrogen. So bioidentical just means it's in the same form as what the human body makes. Non-bioidentical, a different form. That's important to note too, because we do have some data that shows that bioidentical hormone regimens may be safer for humans. I mean, that makes sense. Like, just spend billions of dollars, researching that, but that would make sense at the outset. The non-bioidentical regimens. But I want to be clear, bioidentical hormones are still synthesized. Bioidentical estrogen, the kind of parent compound, comes from soy, but then it's then synthesized in a lab to make it bioidentical estrogen. And bioidentical progesterone comes from yams, but it still needs to be synthesized into human bioidentical progesterone. And I wouldn't throw out all the non-bioidenticals out there. They have a role to play too. There may be some that may actually be even safer from a breast perspective. There may be some that are better at controlling irregular bleeding. So these are all different tools, but pretty much as a standard, we typically start off with bioidentical estrogen and bioidentical progesterone. And probably the most common regimen for that would be an estradiol patch and micronized progesterone, which is taken by mouth in the evening. And then my third thing, which just comes to this terminology, is FDA approved hormones versus compounded hormones. So basically, FDA approved means somebody like me writes a prescription, you can fill it at your local CVS, your insurance hopefully will cover it. That is something we should advocate for coverage for these or improved coverage for these. Compounded hormones are made to order in a compounding pharmacy on site. There is a lot of also back and forth about and a lot of extreme views on, always use FDA, never use compounded. Oh, always use compounded because that's more customized for you and safer. No, they have their pluses and minuses. FDA approved hormones are maybe bioidentical or not. So we can definitely choose from a number of bioidenticals there. They have gone through the FDA approval process, so there's a greater regulation and certainty on that you're getting what you're getting. They're cheaper and access is better. Compounded hormones, yes, you can customize them more. You can use them, especially in the case of allergy, but they are more expensive and regulation is not the same with those. So I would say, in our practice, we typically use FDA approved bioidenticals first. Yeah.
And you mentioned, this is so helpful because I think this is often not discussed, but you also mentioned you can use vaginal, you can use, you talked about the patch, there's discussion of the gel, and often, a provider will just sort of say, which one do you want? Is there a reason you would choose one over another as a patient?
Yeah, so there are many, many regimens and many combinations of regimens. We actually make it much easier for patients in terms of suggesting certain things. And that's just because there are so many different options. It's hard to choose, and many of them can be kind of equivalent. So for estrogen, we choose the estradiol bioidentical human estrogen patch that you change twice weekly. There are some that are changed once weekly for these reasons. It's most easily accessible. It's least expensive over time. And lots of people maybe will go over that, but there is no limit to using hormones anymore. You can use them. My oldest patient on hormone therapy is 86 currently. Okay. So if you're going to use something for a long time, you may as well save some money over time. And it also results in more stable levels of the hormone, and it's predictable. The gels also have bioidentical. This is Divigel or Estrogel. They have also bioidentical estradiol. They are not as well absorbed, so often the doses are different there, and they do require daily administration, but some people love that, so that's okay. There's also a spray one can use. It's tough to get that product these days. And there is a vaginal ring that can be inserted for 3 months too. That ring, it's a great solution if we can get it. Tends to be, again, very costly because it's not commonly used. So, there are also estrogen tablets, right? We all are used to, the pill came out decades ago and millions of women have taken it. There are also tablets that we can take in terms of estrogen. They do have a different heart health or cardiovascular safety profile. So overall, transdermal, so through the skin, estrogen is going to be safer overall than oral estrogen. And for that reason, it's usually transdermal estrogen and oral progesterone that's taken.
Okay, that's really helpful. And as you're talking about safety, really, what are the most common fears that people have around use of hormones? And really, I know many of them are also myths. So what are the things you hear that are easy for you to kind of
Yeah.
myth
So,
bust?
so a couple of things here. So I think when we talk about risks, we have to differentiate between potential side effects versus real health risks, right? So any intervention, anything that we consume, eat, any medical interventions can have side effects and its own risks, and hormones are not different. And I often tell my patients that hormones are like salt. Like if all of a sudden salt goes missing from your food, you're gonna be like, something is off, this is missing. Oh, maybe I need salt. You're not going to go in there and dump a whole salt shaker, right? Because too much is not great. So the right amount, and we differ in how much salt we like. So it has to be the right hormone, the right regimen for the right person. I don't know that. Sometimes it is a trial and error until we find the right one. So side effects can mean that somebody is sensitive to a hormone in a way that's not usual, or they are getting too much of it, or their symptoms are not resolving, they're not getting enough, right? So there are different profiles for these symptoms, but basically too much estrogen is going to feel like, for those of you in the audience who have been pregnant before, it's going to feel like being pregnant. Feeling heavy, maybe retaining water, feeling swollen, tender breasts, bleeding can be a sign of too much estrogen. Too much progesterone. Progesterone has a sort of a soporific sedative effect on a lot of women. So kind of feeling drowsy, feeling kind of foggy the next day, feeling almost dizzy from it. can be side effects. And then about 5 to 10% of women will be very sensitive mood-wise to progesterone, depression, mood instability, crying, that type of thing. But those are side effects. That's different from risks. When it comes to risks, there is a cardiovascular risk from oral estrogen, that just like a birth control pill, it can potentially increase the risk of blood clots, heart attacks, and strokes. This risk does not seem to be there when we use transdermal estrogen. So this is a big reason why we go with transdermals first. Breast cancer, this is one of these super complex areas where we are in 2025. The thinking is that hormone therapy, when initiated around the time of menopause, especially in these sort of more modern regimens, does not raise the risk of breast cancer over baseline for at least 5 years of use. We don't know. We don't have good studies going beyond that to say for sure it does not. So that's something, that's a risk-benefit conversation. Hormone therapy may accelerate the growth of a small breast cancer if it's there, particularly if it is hormone sensitive. And over 80% of newly diagnosed breast cancers will be hormone receptor positive. So we have to think about that too when we prescribe it. And then finally, there is a risk of bleeding and uterine abnormalities, and including uterine cancer, especially when we do not have enough progesterone or progestin component in the regimen to counterbalance the effects of hormones. But my most important thing is that it's a really nuanced conversation. We're not a walking. It's kind of drives me a little bit crazy even sometimes when I read notes from breast surgeons. Like, hormone therapy is not just about the risk of breast cancer. Like, we need to integrate and look at our care holistically. It's, if I go on a plane to Italy, I do that because I want to go on a plane to Italy and I take the risk of that plane coming down, right? If the risk of the plane coming down to me was more important than that trip, I wouldn't go on that plane. And I think
Right.
this is where that really individual conversation and weighing the risks and benefits comes into play. It's not a one size fits all, and there is not a single best decision for everybody out there.
Yeah, that's right. Yeah, I think that's really helpful. And I think there are also a subset of women who really just don't want to take hormones or can't for some reason. They have clot risk, things like that. And so what are the options for them? Particularly with supplements, because I think there's a lot of, if you're on Instagram or TikTok, there's lots of supplements, or at
All
least
the time.
they read my profile, that's what I'm getting on my Instagram feed. So are there any that you can suggest, or are there?
Sure. And I think, that's one of my sort of criticisms of this moment in the menopause conversation. I think the pendulum is swinging so far in the direction of, this is menopause, now we can do something about it, hormones for everyone. And like you said, Marina, like, some people may not want to use them. And for some women, the risk of hormone therapy use may outweigh benefits to them as individuals, right? And we need to acknowledge that. So there are certainly both practices, and I'll put it in the bucket of stuff we can take if we're not using hormones, okay? So there are a number of practices that are really evidence-based and that are incredibly helpful. And here, the two that have the most evidence behind them are CBT for insomnia. So that's cognitive behavioral therapy for insomnia. It's different from like, oh, I go to therapy for 20 years. It's very goal-oriented and different. And I think that can be helpful even for those who use hormone therapy, who still wake up at 3 a.m., like me. So, so it's a really great tool. The other one is hypnosis. There's been a lot of research done on hypnosis, especially in breast cancer patients who typically are not eligible to take hormone therapy, but in general as well. And the third one with less evidence, we certainly do see benefits from it in practice, is acupuncture. So that's practices. On the sort of stuff to take part, there are medications that are used that, as either their primary effect or a side effect, can help with menopause symptoms. So for example, certain antidepressants. This group has probably heard words like Zoloft, which is sertraline, Effexor, which is venlafaxine, Lexapro, which is escitalopram. Those are SSRIs and SNRI medications that can be quite helpful when it comes to sleep, hot flashes, mood instability. They will not do much for your bones, but when we're talking about acute symptom control, that's helpful. Excuse me. There is also gabapentin is frequently used, especially for women who have trouble sleeping. And there's a new sort of kid on the block, and this medication was approved maybe about 2 years ago, called Veoza, which is it's really interesting. It's a drug that targets the regulatory center in our brain that regulates temperature. and really can be helpful with hot flashes. Nope. I'm so sorry. On the supplement front, there's, oh my gosh, my phone is full of these ads also. Okay, here's my thoughts on supplements. One is lots of companies are promising a fix for all in one bottle. All these blends, they are not that effective. I apologize for my cough. So I would take that with a grain of salt too. The way I think of supplements is, and my brain likes to categorize things and organize itself that way. So that's why I'm sharing it like this. We can use supplements to replete certain deficiencies. These are going to be things like your B complex, B12, vitamin D, magnesium, right? These are pretty non-controversial, quite safe, but we can't forget about them. I recently had a patient who showed up after being treated for 3 years with different hormone regimens, who still wasn't feeling well, and her issue was energy. Nobody ever thought to check her B12 level.
Yeah.
Her B12, she was completely deficient in B12, and rather than, throwing things at the wall, seeing what other regimen can work, I mean, the fix was exceedingly simple. And I think that case represents our kind of lack of connecting the dots in how we think in the healthcare system. But that's as an aside. So those are quite safe. And I do think that something like magnesium, vitamin D, B12, especially if there is a deficiency, and for magnesium, even if you haven't had it tested, it's quite, the range of safety on magnesium supplementation is quite well established. It's difficult to overdose on it. The worst thing is going to happen, you're going to poop a lot. So, that can certainly be tried, especially for things like sleep, anxiety, muscle cramps, things like that. Then you have supplements that are aiming to do something or correct a symptom. And here for supplements for menopause, I divide them in my head and with my patients into supplements that kind of sort of look like estrogen in nature, are not bioidentical estrogen, but maybe can bind to our receptors in a weak way.
Right.
And that those are going to be, for example, red clover or black cohosh, right? Or many of the soy extracts are going to do that, versus things that don't bind, or something called rapontic rhubarb is going to bind to our estrogen receptors. Okay, I would not use them for a patient of mine who has breast cancer, for example. So there we would go to other non-estrogenic supplements. Things like 5-HTP, for example, it's a precursor to serotonin. We may use that. Saffron can be a really great choice. There's also kind of green tea, curcumin extract. This is I'll say, because there's only one product on the market. I don't have anything to do with any of these products or companies, but that one is called Thermella, and it may be helpful. So it's important to know what we're doing and for what purpose there.
Yeah.
And use them wisely.
Yeah, I've never heard anyone talk
Yeah.
about it that way, so that's perfect. So helpful. I know there's actually lots of questions, so I want to be able to dive into those. So I'm going to invite Marissa Greason on. Clearly, we need a part 3. So
Totally. Yes.
Marissa Greason's going to come on and help us with some of the questions that are coming.
Perfect. Thank you so much. Thank you both. This has been just so informative and so eye-opening. Thank you, Dr. Barbieri and Dr. Catalozzi. The questions that we have so far, let's see now. I think you answered this one, but let me just say, we've got a question from Pamela who says, can you please speak to calling HRT MHT instead? Because as older women, we're not missing estrogen. We shouldn't have estrogen and don't need anything replaced. That's a feminist take on HRT I saw in the Menopause Manifesto by Jen Gunter. I see Dr. Barbieri shaking her head.
Yes. So I don't know if I think we covered it earlier. Yes, the correct term for menopause hormone therapy now is MHT, whereas HRT means hormone replacement, although lots of times these terms are still being used interchangeably.
Okay, thank you. The next comment. I'm on MHT, love it. Hot flashes of my body and temperature reduced. My question, I've heard a couple of people talk about the benefits of testosterone to bring back some lost energy. My GYN seems to think it's flaky. Thoughts?
Okay. Testosterone is kind of the third main sex hormone in women. We all have it. Testosterone peaks in our early 20s and then declines with time. There's been a lot of research on the use of testosterone therapy for women. Unfortunately, that research focuses on our sexual health. And this would be the crowd where we could, in session 3, talk about the societal, undercurrents of how women's health research is done and for what purpose. But that is what we have testosterone research on. Testosterone use does improve many, many factors of sexual health, libido, arousal, orgasm, all of that. And in our societal guidelines, certainly everyone agrees that testosterone can and should be used for that purpose if there is no other obvious reason for low satisfaction with that realm of our health, right? Because sexual health is very, very complex, and testosterone can do a lot, but it won't do everything there. So we have testosterone for, it's mostly prescribed, it's mostly prescribed for sexual health benefits. I will say on this call that as a, that off-label, many, many women report improved energy and focus with it also. It's administered differently. Levels need to be checked and monitored. It has a more narrow safety window. There are definitely side effects of testosterone and consequences of using too much for too long that actually may not be reversible. So while physiologic testosterone use can be done very, very safely, we do it all the time. Sort of supraphysiologic testosterone is really, it's too much salt. So yes, this is when, hair loss, acne, oily skin, those are all reversible. Voice change, not reversible. Clitoral change, not reversible.
Okay. Thank you. Thank you. And I think we do have our 3rd session that we're going to schedule.
Yes.
Okay, next question. Would you recommend starting hormone therapy when you have symptoms but are still getting periods?
Yes, 1,000% yes. So we're not technically in menopause or postmenopausal until we have not had a period for 12 months or longer. However, we can become symptomatic a long time before, and this is why perimenopause is still kind of underappreciated and understudied. Like I will tell you, I had symptoms 8 years before my last period. I didn't know much about menopause. I thought I had a brain tumor at that time. So it was, and my symptoms were terrible, actually, thinking back to that. So I think it's really, perimenopause is one of those transitions where symptoms can be sometimes subtle and sometimes not really related to our periods, but have very much to do with our hormones. So hormone therapy can be started in perimenopause. My preferred time to start it for patients is either when they are clearly symptomatic from hormonal changes, or when they are in late perimenopause. And what that means is that your periods have started to skip and you're clearly showing some symptoms of estrogen falling, and started definitely no later than 10 years from that last period, but as close to it as possible. So for the question of can it be started in perimenopause? Absolutely.
Okay, thank you. What are the options for those highly sensitive to hormone changes for whom MHT aren't effective or actually make symptoms worse?
I think it's a difficult question to answer in 30 seconds. So I will share with you how I would think of it as a clinician. So to me, I would say, I really need to understand your symptoms and their pattern. What are they? How do they occur? What triggers them? And what happens with hormone therapy for you? Are we dealing with sensitivity to hormones? Are we dealing with common side effects? Or are we dealing with an incorrect regimen or choice of the hormones for you? A great example would be someone who is just starting perimenopause, where the biggest hormonal feature there is not estrogen plummeting. It's actually estrogen that's erratic and maybe very, very high, but progesterone is getting very low. For that person, full-on MHT with regular standard doses of estrogen progesterone is not the way to go. She may need a little bit of progesterone only. She actually may need to use certain tactics to decrease those estrogen spikes. So it's really so complicated. Great question. It's just too complicated to answer with like a one-sentence thing.
Thank you, Dr. Barbieri. Another question. Can you speak to non-hormonal solutions for weight gain in the midsection?
Oh, yes. Okay. I'll answer this for sure, but a very interesting topic to me as a woman and as a clinician in this space is our relationship to our weight and the use of weight loss medications. So menopause is basically a tipping point for cardiometabolic health, and weight gain is part of that manifestation. We tend to gain weight with age. We tend to gain weight in the perimenopausal transition. We gain weight for genetic reasons, for lifestyle reasons, for environmental reasons, for hormonal reasons. There are non-hormonal, so MHT is not a weight loss tool. If we want to talk about losing weight or improving and improving our cardiometabolic health through weight loss, the primary way of doing that is through altering our nutrition and how we eat. Here we can get into behavioral sort of tools about how to do that, and supplement and pharmacologic tools. Unfortunately, none of the supplements that are marketed as nature's Ozempic, let's just say, really work that well. Berberine probably comes closest to something that may be somewhat effective for weight loss. It is not a GLP-1 meaning glucagon-like peptide 1, which is going to be the medications in the Ozempic, Wegovy, Mounjaro, and Zepbound categories. What's very interesting is, and this is, I would love to talk about that in part 3, how do we relate to our physical bodily changes, including weight gain in this phase? How far are we going to go as far as fighting the weight gain if weight gain is part of the natural process of aging? And how do we define something that's too much? If I gain 5 to 10 pounds over my baseline, should I just, and I hate that because I can't wear the clothes from 2 seasons ago. Do I really need to lose that weight? And do I need to feel bad about myself for having that weight? And do I need to obsess about losing it? But that's different than maybe I've gained 25 pounds over my baseline. And what if I'm already starting to show changes in my cardiometabolic health, whether that is cholesterol, high blood pressure, or now I'm pre-diabetic? How do we solve that? Where do we draw that line between not defining ourselves by our weight, right? That's my Generation X feminist coming out. But I also recognize that carrying too much weight, especially too much weight in our belly, that's not just, that's not healthy either. So my 30-second summary is that the management of cardiometabolic health, including weight, is absolutely a part of how we traverse perimenopause and menopause, and that we need to combine those approaches. One doesn't exist without the other. And I think, especially with GLP-1s being on the market, we already know how effective they are for weight loss and how they can correct a lot of the sort of cardiometabolic dysfunction that happens when things go awry. I do think that the use of these medications, this may be a controversial take, will be part of hormone therapy in the future. We're seeing remarkable changes with them. The very complex question is, this is a great development and it's progress. It's a great tool to have. There's issues of cost and access. There is also, how do we approach our environment and food quality, safety, nutrition, our stressed out lives that contribute to all of this. So now we have this Band-Aid that solves it. Great. We should be looking at the root causes of that. Yeah.
Thank you. We are at the hour. We still have a couple of questions. I'm not sure whether we can continue, but I'll ask another question. What is your opinion on using MHT to improve/protect bone density for women 65 or older?
All for using MHT to protect bone density. The real sort of part of the question that's difficult is, are we starting MHT for this person at 65? Meanwhile, on average, this person would have been in menopause for over 10 years, or are we continuing MHT? If the question is continuing, absolutely, 100%. If you're feeling well and we're using it for bone density or other things, let's continue. The question becomes, can we start it? There is a higher risk to starting MHT more than that decade after, but that is not written in stone. That does not mean that we can never, ever do that. It requires a thorough conversation with that particular person on their individual risks and benefits, particularly cardiovascular risk, and whether MHT the risk will be offset by potential benefit. Age 65 comes up because that is technically the age at which bone density screening is approved by insurance. I mean, let's think about how that's really not right. We start to lose bone density. We only accumulate it until our late 20s. We start to lose it from then on. We really start to lose it at menopause. Why are we waiting 15 years to then have to make this decision? I think doing a baseline in your early 50s is the right time to do it, because that can help us decide even sometimes on MHT versus not.
Okay, thank you. Next question. Nearing 70, hot flashes and night sweats, still super active for 22 years. positive osteoporosis, strong breast cancer family history, anything to do, tried gabapentin.
So gabapentin would be fine. Veoza could be a good option there. This is complicated because whereas hormones could relieve hot flashes, night sweats, we're going to be contending with a family history of breast cancer, and the older we are, the higher the risk. And now I'm presuming this person is not using hormone therapy for a long time. So now throwing hormone therapy as another agent into the mix where they have not been around and contending with higher cardiovascular risk. So in this setting, I probably would not be as sort of liberal in terms of hormone use, but focus on the other kind of non-hormonal aspects. Something like hypnosis would be great because it doesn't have other risks to it as helpful with symptom management, and the non-hormonal medications also. And for osteoporosis, there are actually osteoporosis therapies that are going to be more effective in terms of treating osteoporosis rather than hormone therapy is great for prevention. It is not as great in treatment of osteoporosis.
Okay, all right. We've got two other questions here. If previously diagnosed with hormone-sensitive precancerous conditions of the breast and uterus, can MRT ever be reinstated?
Okay, great question, and things are evolving in this space as we speak. There is a movement in the breast oncology circles to de-escalate treatment for precancerous lesions. So I think many of us have heard of DCIS, which is really, DCIS is sort of stage 0 cancer, but it's not really invasive cancer, and to really reformulate our approach to it. Currently, we proceed very, very carefully with hormone therapy for women with a history of breast cancer, and somewhat carefully for not, I mean, always, the decision is always careful, but more options for women with things like atypical lobular hyperplasia and sort of higher risk lesions. Things are changing though. Just, there is a trial that's concluding now at Northwestern. The abstract was just presented about using certain formulations of hormone therapy that actually may prevent progression, which is very, very exciting. So, it's not bioidentical hormone therapy. It's actually Premarin, the horse estrogen, combined with a non-progesterone agent. We have been using it in our practice for women, especially at higher risk for breast cancer with these lesions in the past, and osteopenia or the beginning of osteoporosis, because it may be better for your bones and better for your breast. So things are changing there. Yeah.
Okay, great. What labs would typically be helpful in determining whether a person is in perimenopause? Do lab results trump symptoms in deciding when to start MHT?
The answer to the second question is no. Symptoms first. And as far as lab results, it depends on which lab. Hormone levels, especially estrogen and progesterone in perimenopause, can change wildly. I will usually send them if I'm unsure what the patient is presenting with, which part of their hormonal profile, because maybe symptoms are kind of, can come from all these different buckets, or sometimes to confirm my hunch that I'm not sure about. But typically, estrogen, progesterone will not be that helpful, nor will FSH levels be that helpful in perimenopause. But getting back to my story about one of my patients, I will absolutely treat perimenopause as a full body experience, and we'll look at thyroid, we'll look at cholesterol, we'll look at ApoB, lipoproteins, we'll look at hemoglobin A1C, cardiometabolic profiles, we'll look at B12, vitamin D, and ferritin. So, and that is actually more than what the typical guidelines call for. I think that's where I'm going to be different from them. And I just think those levels are very helpful for optimization of the plan we're going to make together.
Excellent. I'm taking Uvifem. Is this considered topical application?
Yes, Uvifem is topical vaginal hormone therapy. It is bioidentical estrogen in vaginal topical doses. It does not require progesterone to be administered with it.
Perfect. Last question. I've started low-dose oral contraceptives last year, and they've also helped with some perimenopause symptoms like night sweats, some mood fluctuation, interrupted sleep. At what point would you switch to MHT?
Sometime between, and it's pretty arbitrary, sometimes between the age of 51 and 55, or when one develops contraindication to oral contraceptive use.
Okay. All right. That is
If
no more
I may,
questions.
question that showed up, I think, twice, so I'll just answer it quickly. Is there evidence that HRT or MHT should be started if perimenopausal with diagnosis of osteoporosis? So MHT is not first line for osteoporosis treatment, but if someone is in perimenopause and it's early osteoporosis, yes, we're going to definitely consider MHT along with exercise, weight training, adequate protein, adequate vitamin D, and calcium. And osteoporosis in perimenopause is not that common, so typically a workup would be done to look for other non-age related and menopause related causes of osteoporosis.
Thank you. Thank you. At this point, we don't have any more questions. I want to just take the opportunity on behalf of the Project Continuum members, and thank you to Rona as well, but thank you so much, Dr. Catalozzi and Dr. Barbieri, for this wonderful presentation. I think we could go on for another hour if we had so, but thank you for your time in extending this beyond the 8 o'clock hour. So to all those that are still on the call, thank you so much for joining us. We do appreciate it. And we hope to see you in the fall, and have a good summer. Rona, is there anything that you would like to add?
No, I think just stay tuned for part 3.
Yeah, absolutely.
Thank you so much.
So thank you, everyone.